Hello, my name is Joy Ashby Cornthwaite, and I will be your host for this episode of the live stream show, MyDiabetesHQ Live. This weekly broadcast is developed and produced by Cities Changing Diabetes volunteers from here in Houston and our sister city, Philadelphia, which recently joined the global network of 25 cities working to improve diabetes prevention, care, and management. You can learn more about Cities Changing Diabetes by going to citieschangingdiabetes.org. The purpose of this effort is to help people with diabetes and their caregivers successfully transition through these very challenging times of COVID-19. Each Saturday, we gather diabetes care experts to discuss and to share their incredible knowledge about diabetes. They have years of experience in self-care, medical care, public health, community health, and advocacy. And we will bring this knowledge straight to your waiting eyes and ears. We hope that these conversations will give you the tools to build skills to better manage diabetes and to live your best lives, not only surviving diabetes, but thriving and doing the things that you want to be doing. Today's episode is coming right up. You don't want to miss this. Hi, everyone. Remember that the content that you see here on MyDiabetesHQ live broadcast is not intended to substitute for your professional medical advice, diagnosis, or treatment by your physician. Please seek advice by your doctors. So hello to all you diabetes warriors, champions, and advocates. Welcome to this episode of MyDiabetesHQ Live. To our viewers on MyDiabetesHQ Facebook, and MyDiabetes YouTube channels, thank you and welcome to our show. We're happy to have you here this morning. Today's format is designed to give you, our viewers, the opportunity to ask questions of our amazing guest physician, Dr. Rao. He is an endocrinologist and professor at Temple University, associate professor at Temple University College of Medicine. We'll begin with some advice born from our very own experiences in our work with people living with diabetes, and weave in live questions from today's viewers. We will try to get to as many questions as possible, but if we don't get to yours, please leave your comment down in below, and we'll get back to you as soon as we can. So today, we will be discussing strategies for continuing self-care, even when the stressors of COVID-19 have begun to weigh in on us, as individuals, as friends, and as families, and as communities. Diabetes by itself can lead to emotional and mental fatigue for those living with diabetes, but also those around them who provide support. Today's broadcast is going to be dedicated to recognizing diabetes distress, giving voice to that fatigue, acknowledging caregiver needs, and raising awareness of the resources and the ways that entire care teams can support one another. For people living with diabetes to continue to thrive, we have to do this. We're excited to be able to receive advice from Dr. Rao and from my colleagues, Serena and Maryanne. Don't go anywhere, because this information about people living with diabetes, caregivers, and clinicians can add to your toolbox to take care of yourself. So especially now, we're calling on everyone, hands in, to support one another. So let me welcome Dr. AJ Rao. Good morning, Dr. Rao.
Good morning. How are you?
I'm wonderful. I'm so excited to have you here with us.
Yeah, excited to be here. It's a lot of fun.
Yeah, and our last time together was so great, and we got a lot of rave reviews, and so we want to just mimic that today. We know that you're also on the advisory board of Cities Changing Diabetes Philadelphia.
Yeah, that's been really exciting to be involved with here in the city, and we're really excited to see where it's going to go.
Awesome. So we also have Serena joining us, CEO of Core Initiatives here in Houston. She's bringing her experience as a person living with diabetes to the table to give voice to things that people need. And also, she is program coordinator for a Cities Changing Diabetes initiative here in Houston called Diabetes Peer Support. And we're going to touch on how important peer support is during this time of diabetes distress and fatigue. And rounding out our table, Maryanne Strobel, registered nurse and certified diabetes care and education specialist.
Good morning. So nice to be here with everyone.
In addition to her inpatient and outpatient work, she is moving right ahead with all of her work for disaster preparedness. So we will talk about resiliency and preparing ourselves so that, you know, it makes a lot of things easier if we have a heads up and we know what we're going to do in certain situations. So good morning, everyone.
Good morning.
All right. So Dr. Rao, can you begin by just talking to us a little bit about this idea and theme of fatigue and the stressors that are weighing in now?
Sure. You know, I think for all of us, these last couple of months have been very challenging, and I think that, you know, those, you know, living with diabetes have a lot to take care of on a day-to-day basis. And then you add on sort of the pandemic and public health emergency that we're part of. And I think that's been very challenging for folks to handle, whether it be, you know, jobs changing, lifestyles changing, not being able to get out and exercise and move around as much as they're used to. So those outlets are no longer there. And I think that can be sort of a vicious cycle for a lot of our individuals living with diabetes and those even living without diabetes.
Yeah, team, what are you all hearing about this and you know, how do we begin this conversation in order to get people to say, you know, maybe that is me. Maybe I do need to ask for some help.
What I've been experiencing in peer support meetings, virtual, of course, a lot of people, especially with the peer, you know, situation, a lot of people will speak up when they see other people speaking up. So in the setting that I'm in, usually I'll start the conversation by talking about how I feel myself, and then ask, is there anyone else feeling the same way? And there may be one person that may say something, and then everybody else kind of chimes in like, yeah, me too, I feel the same way. And then that's how we get the whole conversation going.
Yeah,
and I'm working. I'm sorry.
I was just going to say the group setting works perfect for that. You know, I think the peer aspect is so nice to see amongst our patients. So sorry, go ahead, Maryanne. Apologize.
Oh, no, I just wanted to, you know, bank off of what Serena was saying and what you said earlier. You know, I'm talking to some of my colleagues, some of them who are actually nurses who are working directly at the bedside with our very complicated COVID patients. And some of them, of course, themselves, as you know, humans have diabetes, and they're trying to take care of their own diabetes while taking care of all of these patients. And they're telling me they're almost feeling robotic. They're kind of concerned because they said they think they're starting to lose that element of compassion for themselves as well as for their patients, you know, even for their families. They're feeling like the only way they can function right now is to just do a job and not think too much. And they're scared about feeling that way.
Yeah. And so I think that, you know, one of the things that we have to remember is that first we have to be aware, right? So we have to say to ourselves, what am I experiencing? And then be very honest and open with ourselves. You know, I think at the front end of all of the U.S. Preparedness and going into lockdown, this was 6 months ago, y'all. Like, it was March, and we are somehow in August, and I think half of us don't know how we got here.
No, we don't.
So true.
In the very beginning, you know, every single person had to adjust in some way, right? So we went from in-clinic visits where we could have tangible moments with our patients, touch them, hug them, hold their hands as they told us our worries and their concerns. And now we're virtual with people. We went to that very quickly. And I think there's this kind of immediate spike, right? You get aware, you prepare, you're like in it, you're doing it, you're getting there. And then there's this curve where you start to tilt down, right? You're just exhausted.
Exhausted.
Yeah, you're exhausted. And so we need to, I think, maybe if now would be a good time to bring up like resiliency, so that we can see how resiliency is linked to all of these things, right? So emotional well-being, inner drive, focus, relationships, physical health. I think this is the time where, as all of that acute sort of like immediate, let's fix this problem now starts to fade away because it's been here for 6 months, for half a year. I think this is when we need to look at each of these situations or each of these parts of resilience and guide them in our bounce back, help it guide us in our bounce back. So where do you want to start on this, Dr. Rao? I know this is a lot.
Yeah.
Where do you think we should start talking first?
Well, I think it's, I was just, while you were talking, I was just sort of thinking of how, even my virtual or telehealth visits, I've now become a lot more, asking of these questions. And I should have been doing it all along, even pre-pandemic, obviously. And we know that, these are definitely concerns of our patients. But I must say that this whole process has allowed me to ask more of my patients of what's going on with them on a day-to-day basis. And initially, when it's done virtually, you feel like, there's a lot of, you feel like you're just having a conversation with your patient, and it's a lot easier than maybe when it's in person. But now I'm excited to sort of have a chance to even ask these questions in person, because I think I'm definitely have been missing, and you can't, missing this aspect. And I think you can't identify the problem unless you start asking about it. I think is one thing that I was thinking about as you were just speaking there. I think the other thing is that, in that resilience sort of diagram, we know that, a lot of those things feed into each other, right? So for example, the physical health, the relationships can help you focus in on the future and sort of toggle in your inner drive and emotional well-being. And then sort of those things wrap back around to the other aspects. So I think it's just it's just really important to engage in this amongst yourselves, amongst your family members, amongst your amongst your providers of all sorts, because I think that's the only way we can sort of make change.
Mm-hmm. So I think small steps, right? So identify one item and then use and identify how that one item can be modified in your specific daily routine. So like even just a walk, right? I know Serena was telling me about how, I think we were talking offline about how important it is for her to take a walk, and get out. Serena, do you want to say something? I'm muting you.
Yeah. There's so many things taking place and going on. For me, a walk outside is like a breath of fresh air. It's time for me to actually have a thought process that is my own and not for everything or anyone else. So that's like quiet time for me to just be quiet, listen to my music and just walk. And then, physical activity is good for you anyway, takes care of your heart and keeps your blood sugars regulated. But it's a healthy way, because I've had unhealthier ways of dealing with frustration. And so that had been my go-to now to alleviate some stress, is taking a walk.
I think that's a great idea. And I think that's something that I'm hearing is being missed by a lot of our caregivers who also have diabetes is that they're, working most of the time, they're working 12-hour shifts, and they're basically living behind a mask, all covered up with their hair and everything else. And then they go home after 12 hours and they basically just catch some sleep, in the house, and then they're back at work again, and they're not getting outside. And I think it's adding to their despair. And I think you're absolutely right. I think that's one thing that we should all be advocating for doing for ourselves, as well as advocating to our colleagues and our patients with diabetes, is we absolutely need to start getting outside more and or doing some type of exercise. I think you're absolutely right.
Mm-hmm.
So Dr. Rao, a question, how can we practice safely being outside and exercising during this time? Because I know a lot of our viewers are probably in Philadelphia and Houston and really around the country right now saying, these people want me to get outside. It is hot.
It has been very hot, and in obviously both places, all across the country.
Mm-hmm.
So I think obviously I always talk to my patients about having sort of hydration on hand, make sure they have some water or something to take around when they're going outside. But I think to your question about safety about going outside, I mean, I think clearly we want everybody to be adherent to whatever local practice it is for social distancing and mask wearing. But I think at the same time, you can clearly keep 6 feet away going around in most places. And I think even taking a nice walk around the block is better than nothing. And I think, as Serena was mentioning, baby steps, right? Even a small walk a short walk around the block can do a lot for you. And it doesn't have to be a in-depth exercise routine. And just getting some sun, choosing, either the early morning hours or late evening hours when it's cool, can be helpful.
Yeah. And people living with diabetes can do it safely by, taking a water bottle with you, especially since it's so hot right now. You want to hydrate before and during and then after, of course. And then are there any concerns centered around medication or, if I took my insulin just before my walk, is that going to be a concern for me?
Yeah, so I think clearly we're always, those who are using insulin, we want to be careful to make sure patients have some glucose source to combat if they eventually have a low sugar episode. So making sure the patient understands how to identify a low sugar episode, and if they have that, how to treat that, any sort of sugar source that the patients have been informed to by their providers, I think is always helpful to have on handy, especially if you've just administered your insulin and you're doing something that maybe you hadn't done in about 2 or 3 months. That activity can be helpful, which is great, but it might mean that the insulin that you took works better, which means you might see your sugar drop a little bit more steeper than you expect, which is, this is a great thing, but we want to make sure you're aware of that potentially could happen.
Mm-hmm. Excellent. So self-care being about getting out, taking a moment safely, which definitely can be done safely, and then make all the considerations around your treatment plan, and perhaps even discuss, with your clinician at your visit or via telehealth, I'm thinking about starting exercising, doc.
That's a great point. That's a great point. And it can be easily asked to the provider and say, hey, I haven't been doing this. I'm about to start doing this. Any suggestions, any recommendations?
Yeah, exactly.
That's a great point. And that's actually one thing that I always tell my patients, especially since I work in the inpatient setting. And while I'll go and talk to some people, sometimes they're newly diagnosed and they're, really, really gung-ho about making changes immediately as much as they can. And I've had patients already tell me, well, as soon as I get discharged, I am going to start this intense exercise program and I'm going to exercise for 2 or 3 hours every day. And, I tell them, I said, don't do that. You need to talk with your physician because you might have other conditions as well that could be affected. and you haven't been doing this. This is not the time to start doing Ironman training, and so, and so, you're so right, Dr. Rao. That's the exact thing I tell them. I say, you have to get clearance from your physician and have this conversation with your physician before you decide to do this and to take the baby steps.
Yeah.
So, go ahead.
No,
Sorry.
you go, Serena.
No, Dr. Rao, I have $1 million question I've been hearing a lot.
Oh, great.
Million.
Can't wait for this one. Serena's always got the tough ones too. So.
Are you paying him or is he paying you?
Right.
A lot of people are asking, okay, so when I go outside to exercise, mask or no mask?
Yeah, I mean, I think if you can, I think the challenge here is it sort of depends where you are. I mean, I when I go outside in the morning in Philadelphia, it's hard for me to predict if I'm going to all of a sudden see somebody around the corner. So I think if you can ensure you're going to have that 6 feet all the time and nobody's going to be around you, I think you're fine. I think the problem though is it's, when you closely think about that, you find out that there's no way you can guarantee that. And obviously having the mask on and handy to sort of flip up is great, but then that requires you to be touching your mouth and face a lot. So I know it's a challenge to exercise with these masks on, but I think you can choose hours when maybe not a lot of people are around. But again, it's a question that's more particular probably to where you're exercising. And I can tell you in cities like Houston and Philly, you never know if you're going to see a person, especially if you're in the city around the corner, or somebody who's coming up and who may be masking or not masking. So I think that's the challenge.
Okay.
So, Dr. Rao, I have a question that somebody asked me this week. So I sometimes see patients who work outside, and I've had a lot of patients recently who are working in construction, and they're having to share tools with coworkers. And, sometimes there's perspiration on the tools, and they're really worried. Can they get COVID from touching an item that was with perspiration on it? Is that a way of transmission?
Yeah, no, great question. We've had, with a lot of folks maybe staying at home, it's become easier for construction activities to really get going and folks to finish off projects, which means obviously a lot of construction workers out and working. I think the one thing that the knowledge that we have right now, we think about this virus as mostly being transmittable through what we call aerosolized or, sort of, through the air, and hence the masks are so crucial. However, to your point about, things like hammers or other tools that they're using, the issue there is not necessarily moving those around. It's just that when you move them around, you might then touch your face and touch your mouth. And that frequent touching is where I think we get into the challenges. So I don't think there's concern of the actual object itself, but it's the movement of the object and then probably the hand touching and stuff that could lend itself to increased chance of having the virus.
Okay. Is perspiration carrying the virus? Perspiration itself?
I'm not aware of that personally. Again, I think of more of aerosolized as a way that it can go, but I guess theoretically the perspiration can aerosolize, and actually be transmitted that way. I don't know of that, but again, I'm that's from what my knowledge is of what I've been mentioning to my patients.
Yeah. There's so much we don't know yet,
There's been several articles that have tried to understand how this is transmitted, and the bulk of the thought is the transmission is primarily aerosolization, and hence the trying to enforce the face mask is really going to be a big part until we have some vaccine available.
Yeah, and then coming back, whenever I have questions like this from my patients about vector transmission or items that you might touch that someone else might touch as well, and how that could transmit the disease or allow you to get it. It always comes back to please wash your hands, y'all.
Right.
Yeah.
That's a good point.
Water, wash them.
Good point.
Yeah.
Good point.
So I have another question. So I am starting to get my groceries that I'm going to order them, and they pick them out in the store and then they just put them in my car. I go and pick them up so I don't have to go in the store. Do I have to worry about washing off the containers when I bring my groceries in the house? Do I have to wash off my milk cartons and things like that before I put them away?
Great question. To my knowledge, no. I can tell you personally, I haven't been doing that, and I'm very happy that I can get fresh groceries delivered and don't have to go to the grocery store. In fact, if you think concerns is more of if you go to the grocery store, you might be actually amongst other folks who are or not, masking and get into trouble there. So I think it's great to have these options for home delivery if you have that resource available. And I have not been doing that, nor have I been recommending that to my patients.
Mm-hmm.
Yeah, and I think that grocery store conversation has led us, I think, to where, so I'm choosing my groceries and now I need to prepare them to take care of my diabetes. And so we have a viewers asking us how we feel about keto or low carb for type 1. I think she's calling me out because I'm the dietitian in the room.
Oh, I would love to hear your opinion, because I can't tell you how often I get this question, but I'm curious.
I get it pretty often as well. So, my way of teaching eating healthy and living well with diabetes is, of course, not to do anything extreme that allows, that changes the way that you experience life with those around you. I'm more of a holistic diabetes educator, dietitian. So I want you to develop a really good relationship with food. All these kind of individual diet plans are very restrictive. They can also be very, very costly. And so I think in the context of what we're talking about today, in terms of resilience and being mired or being deep in this diabetes self-care during COVID, I think any extreme diets like keto or low carb, first you have to ask yourself, can I afford this? Keto plans, keto specific foods that are labeled low carb, diabetes, all of these things, it gives marketing the ability to upcharge these things.
Mm-hmm.
A really well thought out plan of, am I having my vegetables? What's in season? What is easy to afford? You can plan that, add vegetables, lean proteins, whole grains, and do a combination of those things. And of course, you have to get an appointment with someone who can help you design these things that are, one, culturally appropriate, that fit into your budget, and that you can actually physically make. Okay. Mm-hmm. So I think that the keto and the low carb diets are very, very restrictive. They may not fall in line with your personal care or your medications or the treatment plan that you and your clinicians have come up with. So it's it might seem as kind of a non-answer. I can't tell you exactly what you should do because I don't have all of the information about your personal care. But I think to begin with, just start adding more vegetables, choosing complex carbohydrates or things that have whole grains and fiber in them, and then lean proteins, and start there with the foods that you have, that you know how to prepare and that you can afford.
Mm-hmm. And one of the things that I was thinking about as you were, talking, Joy, you brought up a great point. Also, they need to talk to their physician about if they're taking insulin, especially about their dosages of insulin, because if they're changing the way that they're eating to such a drastic degree, more than likely they may need some adjustment especially with insulin dosages, because I've seen this happen before. A person will go and really go down on their carb amount that they're eating every day, and their physician has already had their insulin dose, if they're taking especially a pre-meal dose, calculated on that amount they're already eating, and now they're suffering a whole lot of low blood glucose levels, low blood glucoses. And so do you have anything more to offer on that, Dr. Rao?
No, it's a great point. You know, in Yanti's question, I think what drew me to the question was, again, you know, what you were just alluding to, which is you know, type 1 diabetes. I think Yanti was mentioning about, you know, the recommendations for individuals with living with type 1 diabetes and these diets. And I think you're absolutely right. You know, there's these diets need to be sort of implemented with some assistance from you know, your diabetes educator and your provider, just because there can all of a sudden be changes in your insulin requirements, and obviously the need to make sure you know how to detect you know, the emergency of ketoacidosis. So I think it's really crucial to you know, when you're thinking of any dietary plan, I mean, it doesn't even have to be keto or low carb, any changes in your diet, the provider has probably calculated certain things for you based on what your usual diet was. And if you're making a big change, that could lead to differences in how much insulin you need, or how the insulin is, how effective or how quickly the insulin's working. So keeping the provider and the educator team engaged is I think really paramount.
Yeah.
Dr. Rao, I think you've answered this on the other show, but if you would answer it, please, again, can you tell our viewers what are ketones? Because I get that question all the time.
Sure. So the ketones are essentially, you know, a fuel that can build up when there's not appropriate insulin effectively going around in your body. And I think the push for the ketone diet has been the thought that this ketone fuel can actually be helpful for the overall body. And I think we've learned a lot of this from more of the type 2 diabetes literature. But I think in individuals who have type 1 diabetes, the concern is these ketones, if they build up, and there's a chance for acid buildup in the body, and that can really be sort of a downstream emergency where you need to seek help, you know, at a hospital facility or emergency room. Get dehydrated, sugars are very high, those sort of things.
And to talk about the secondary question as well. So if you're pushing yourself to sort of these extremes with adjustments of foods, the thought is, you know, I'm going to lose weight. You know, that deprivation is what we're after in order to achieve our goals of glucose control and of weight loss. And those two things, you know, it's very difficult to lead a self-care life that supports you and that makes you feel good if you're in a constant state of deprivation. And so I see that happening opposite, right? For a lot of individuals that come in and we have an amazing conversation and we're able to develop plans that meet all of their needs, in addition to allowing them to live and strive and live their best lives, right? And they're not exhibiting these sort of shifts in mood, or these shifts in elevated blood glucose and very, very low hypos. These things are all really a massive part of resilience. And I know we think of diet as this tiny little component, but just like you were saying before, Dr. Rao, all of these things are interconnected. So if you're practicing a meal plan that's really that deprives you of everything that you're doing, you're probably not doing it with other people, right? So you've lost your social support. You're doing it maybe in a financial vacuum where it's very difficult for you to purchase these things. And so that also doesn't feed resiliency or make you feel good. And so I think we have to also think about, you know, nutrition and food choices and development of a meal plan that's based for you, that takes in your whole self and supports your whole self.
Yeah, I really liked your comment, Joy, about sort of the extremes and the cost. I think the cost is another thing we have to keep in mind. And a lot of these diets out there, again, they may pitch a lot, but in the end, the cost might be really prohibitive. And again, touching base with your team is, I think, really important.
Mhm.
And Yanti is saying, I think she's answering us and saying that she's struggling, they are struggling with lots of low blood sugars after implementing lower carbs.
Yeah, and that can happen. And again, that's where it's really important for you to reach out and see if there's maybe a change that's needed to your your pharmacological, your medical treatment.
Yeah. And a lot of times, Dr. Rao, if we're talking about meal planning and then exercise and hypos, one of the things that I notice, and maybe our viewers can notice this and you can talk about it as well, is when someone has a lot of recurrent hypo events or low blood glucose events, how does that relate to the rebound highs and then weight gain?
No, I think we're constantly trying to talk a little bit about lows and prevention of lows. And I think sometimes as providers, we may not talk thoroughly enough with our patients as to why we want them to not have the low sugars. So, I think you bring up a good point, is that, when these low sugar episodes happen, usually you're going to overtreat and overcompensate. And I think when that happens, you find yourself on the other end of the spectrum, which can be very challenging to then sort of bring back down. And so preventing the lows, I think, is crucial. More importantly, though, if the lows sort of keep on happening, then the problem is you need a lower and lower sugar to actually hit that threshold where you actually get the symptoms. So luckily our body has these, symptoms that trigger us to think that we're having a low sugar. But I think at the same time, preventing those low sugars from happening can prevent these swings, which I think end up becoming a lot of trouble and challenges for many of our patients.
Mm-hmm.
Yeah.
So Dr. Ra, what you're saying is, if my sugar gets really low, I can't go grab a large piece of chocolate.
Well, so you've got to treat it, right? And I think another crucial thing, Serena, is a great question, because we want people to ideally check their sugar to make sure they're actually having a low sugar episode if they can, because we want to make sure they can connect their symptoms with what the sugar is. And of course you've got to treat it, but that's why we talk a lot about having some sort of glucose source on hand so you don't overtreat. We talk a little bit about glucose tabs, but those can be so not tasty and not helpful, right? And so this is the issue, right? Many of our patients have glucose sources that are chocolate cake, and so that works, but then it gets you to the other end of the spectrum. So
yeah, because I know I get a lot of people, like you said, it's important for people to realize that they, when they feel something, check your sugar, because some hypoglycemia events and hyperglycemia events, some of them are kind of the same. They kind of feel the same. Yeah. So it is important for people to check your blood sugar first, because they'll say, "Oh, I feel like my sugar's low. I need to go get a bag of M&Ms." Like, no, you can't do that.
Yeah.
You can't do that. So yeah.
Dr. Rao, can you tell us a little bit about what is hypoglycemic? I'm sorry.
Yeah, before we go forward, let's just kind of address, I think, the treatment of a low, right? So there are a bunch of different options for low blood glucose treatment. Like Dr. Rao was saying, there's tablets, there are actual foods, things like that. So the goal of a treatment of a blood glucose is, and I talked about this a lot to my patients and family members, is to raise your blood glucose, remove the symptoms of the low, and then eat a balanced meal on top of that. So, and a lot of times, not having things ready is what allows you to panic, and then you kind of just do whatever because you're just trying to protect yourself. And so thinking about the things that you like to treat with, because some people have been on this journey for a very long time. And so glucose tablets have been something that they've been using forever. And there's just like an internal dislike for those things. So whatever it is that you prefer to use for a treatment, discuss it with your clinician. And one of the things that I found is really, really beneficial is to actually hold those things in your mouth. Okay, so if you're having M&Ms, instead of continuing to eat the M&Ms, chew the M&Ms and hold them in your mouth. The cells in your mouth start to digest that glucose and that sugar, and it starts to raise your blood glucose in your mouth. That's what your saliva is for. It helps to digest and start breaking down sugar from the get-go. So it might be something, if your GI tract or the way your food moves through your body is slower, it might take a really long time to receive the glucose if you swallow it. But if you hold it in your mouth, it tends to work a little bit better, a little bit faster. Okay, so and that might be chocolate cake. It might be the M&Ms. It might be the glucose tablets. You just never know. But hold it in your mouth. It saves you from doing a couple of things. One, over-treating, so that you get like the opposite, really, really high highs. And it allows you to, take a moment with that food if it's something that you don't normally allow yourself to have. And so I think that, treatment for a low blood glucose looks different from from person to person, just like with much of diabetes care. But that you can have a discussion and be, part of resiliency is preparing, right, Maryanne? Right.
Oh, absolutely. Absolutely.
And so prepare to know how to take care of yourself. And then your blood glucose will go from a low or hypo to maybe, a high low. And then you can make really great decisions about how to move forward.
And I think, it's also great to talk to your providers when you have these episodes after, when you're seeing them at the next visit, whether it's virtual or in person, and say, oh, here's what, I had this low episode, and go through the steps and see what happened and make sure that provider knows that that's happening. What are you using to treat? Did you recover appropriately? These are things to learn from so that with the next episode, you're prepared.
Yeah.
Right.
And actually, Dr. Rao, I actually tell my patients that if they have 2 or more lows a week, just even having 2, they should try to get in contact with their provider and have a discussion, especially if they're taking insulin, because as you said before, they may need some type of an adjustment with their dosages. And I tell them not even to wait till they have their next appointment, that I think it's important enough that they should give a call to the doctor's office. And at least let somebody know that they've been having that happen. I wanted to also ask about hypoglycemic unawareness, a big long word, but we know that we have patients that have had diabetes for quite a while, and just as Serena was saying, that sometimes the symptoms of either high blood sugar or low blood sugar can kind of start to seem similar. So is this really a condition, this hypoglycemic unawareness, and really what is it from a physician perspective?
Great question, Maryanne. I mean, it's definitely a condition that we see, and it can happen both in individuals living with type 1 or type 2 diabetes. So essentially what happens is that, luckily our body has this system that triggers kind of that fight or flight stress response, right? Because the low sugar episode is pretty much like the cheetahs chasing you, right? And so you have all these response elements in your body to bring that sugar up and get those symptoms to be triggered in your body. So all these hormones get sort of activated when the sugar is low. The unawareness problem is when individuals have had repeated bouts of low sugar episodes. What happens is that it takes a lower and lower sugar level for you to actually feel the symptoms. So you get unaware of low sugar. And the problem with that is it's not, when I talk to my patients, I say it's really not a big problem for the rest of your body, but it's a problem for your brain, because the brain can really only use sugar. And so if you're just sitting there and your sugar is 30 or 40, and the patient's having no symptoms, we get really worried, because then there's no way for the patient to treat themselves. Nobody thinks something's wrong. And then again, most importantly, they're depriving their brain of sugar, which is a big problem, maybe in the long run. So it is a huge issue, and it's something to bring up, which is why, I was talking about earlier about bringing it up to your provider, because walking through what happened during that episode is crucial.
Oh, yeah. And especially with people like, being isolated. So if you've got people that are living by themselves, and now they're getting this lower and lower threshold of when they're going to get symptoms, they really need to be having that conversation with their provider and their diabetes care and education specialist, and within their peer group as well, just learning more about this, because it can be really, really scary and be very tragic.
Yeah, no, that's another very good point. And to sort of just dovetail off of that is we're so excited with all the variety of emergency treatments that are now available, which is really nice for patients to have on hand as a resource if these things happen.
Yeah. So one of the questions that's coming up is on this theme that we have here. If you don't feel your lows after having diabetes for a really long time, will you start to, can you fix that brain glucose?
Looks like Serena's got the answer.
She's not the answer.
Valentine.
As my team already knows, I've been dealing with diabetes for 17 years. So I've started to notice, when I start to pay attention to myself, which is even all about self-care and being prepared. You pay attention to yourself when these things happen. What I've noticed, and this sounds weird, y'all, so don't laugh at me, okay? But I can tell the difference between my highs and my lows, because when my blood sugar is low, I'm anxious and I want to cry. When my blood sugar is high, I'm anxious and I'm angry. So I've put those two things together. So I notice if I'm angry, it's high. I check my blood sugar. It is indeed high. If I feel like I want to cry, my sugar is low. And this is not all the time. Other things happen that make you have those other, those other emotions. But when you know that there's nothing else going on, and all of a sudden, I have to do that. If I feel like I want to cry, I'm like, oh, let me check my sugar, and it's low. So it's just like paying attention to your body. Everybody's body's not going to do that like mine. Okay. But the whole point is for self-care is to pay attention to how you feel every time these episodes happen, and distinguish between your highs and your lows. And that can actually help you be even better prepared in the future.
Awesome answer.
Yeah, that's great. No, I mean, I think
weird, but as
I think the individualized response is something really crucial, right? Every patient's we talk about classic symptoms, but I've heard of patients tell me a whole slew of various things that happen to them during low sugar episodes that might be helpful for you to detect and understand. I think, to Reva's question, though, I think it's hard when you say better control. It also probably has to do with if you can get the sugars probably not fluctuating as much, there is a chance maybe you'll start getting those characteristic symptoms back again. But again, it's a case-by-case basis, and it's really hard to probably pin it down unless I know a lot more details of the patient. I think duration of illness, duration of diabetes is one aspect of it, but it can sometimes come back in certain patients.
Yeah. So to that question, sometimes we have individuals who are asking, I felt better at a higher number.
Yeah.
So, some individuals, when they first come in, we may start medication, treatment, therapies. and our goal is to reduce the blood glucose. But what happens when that happens, Dr. Rao? So
Yeah.
at 300, my patient feels perfectly fine, but at 150, this person is like, this feels terrible. Let me get back to 300.
You know, I can't tell you I can't tell you the amount of times. I mean, you guys have heard this all the time, probably from our patients, you know, and as a specialist, for me, it can be sometimes even more challenging because they're referred, and then I see them, I sort of implement a sort of an additional plan, and then they not only start doing what I told them to do, but they start doing what their primary care told them to do, and sort of it's a double whammy, and they all of a sudden have a drop again into the normal range, but for them that's low, and so we try to talk to our patients a little bit about we try to gradually bring individuals down so that they can get more used to it. I think they have to invest in checking their sugars when they're having the episode so they understand if they're truly having a low sugar episode. And it is very difficult. We are very understanding that the patient's not feeling right, but we try to tell them that we're in this for the long game, right? We want to get their sugars under better control overall. And so we understand it's going to take some time for that to happen, and it's just a matter of getting used to those newer numbers that are a little bit better controlled than they're used to being.
Yeah, and so to come back, having these questions answered, I think, Dr. Rao, I know that it's a really concern for our friend Yanti here. So taking all of these components and putting them together, now when we see, you know, I'm in my clinician brain right now. Now, when we come back to Yanti's original question of struggling with lows after implementing lower carbs, what I'm wondering is was there, you know, and this is something for Yanti to answer and to discuss with his with their clinical team, but is it a layering of all of these things? You know, maybe went to a diabetes educator and went to primary care and went to endo, and all at the same time experienced lowering blood glucose values through food changes, lowering blood glucose values through medication, lowering blood glucose values through diet. Just how important is it that we all together with our patients understand that the expectation is we really need to come back to our clinician within a week or two of making some of these changes, right?
Yeah, the touch points are crucial. Frequent touch points during these periods are really important, and I think that's a challenge that we face in clinical delivery, but it is something that we need for diabetes. It's crucial.
Yeah, and so that repeated, you know, all of those things, we want to say, good job. You are doing things that have changed the course of your diabetes, and so everybody has to be involved in that change of course and coming back to it. So the change of course, one of the things that we look for in change of course is this A1c. Who wants to tackle Hemoglobin A1c, which is a super name, by the way, by some She's like, not super name.
I guess, I mean, great test, right? For us to sort of monitor how individuals are doing. You know, we some investigators or physicians some years ago were able to figure out that, well, let's just use our blood cell turnover, our hemoglobin, and how sugar attaches to that to sort of figure out overall long-term sort of 90-day control of an individual's, individuals living with diabetes. And so we use it not only initially when it was brought out, it was used to sort of track how people were doing, every 3 months or so. And then, then it became part of the diagnostic criteria, right? So we can actually diagnose individuals with diabetes based on the A1c, as that was brought out within the last decade. And that helps because you don't have to be fasting when you're checking the A1c, and that allows a lot of quick testing to be done in patients who might be at risk for diabetes. So essentially, it's essentially just another way of assessing how is your overall sugar control been over the 3 months. It does not replace point-to-point measurements. And to our point, we were talking about hypos. I always talk to my patients, you can get to a flat level or nice average glucose level two ways, right? You could either be continuously doing great like this, or you could have a wide spectrum and that averages out to being okay.
Yeah.
And so that's why, the A1C is helpful, but it doesn't replace the point-to-point checks.
Yeah, I agree with you, Dr. Rao, because I see this often too. And I get patients who are so focused on that A1C. And what I have to remind them is, as you said, you can get to that A1C level where it's looking where you think you want to have it, either because you have been maintaining your blood glucoses within that, what has been established as your normal range, or you've been having those wide fluctuations. But I also, because of working in the hospital with very complex patients, there's different disease states that can have an effect upon that A1C value. And then we also know that, besides those, what we call comorbidities, those other conditions, there's also, during the times of pregnancy, patients that are on hemodialysis, patients' age can play a factor, and then of course, how many hypoglycemia they've been having in addition. So I always tell them, it can be individualized. And that is a great question to have with your physician or your provider, because it might have to be individually established as to what your goal really is.
Absolutely. Yeah.
And since it's an average, you can have an average of, 30 plus 300 and get a really good looking number,
right,
with while missing the fact that you've been having 30s and 300s.
Right.
And so, like Dr. Rao says, for sure, make sure that you're checking your blood glucose, however you're able
Yes.
to, in real time, so it can tell you the real time information. Yeah. So, guys, our viewers out there, we're getting down to the wire here. So put in your questions so that we can answer them. And one of the questions that I've had that people have brought to me is, what about for the people who are not living with diabetes, but what about the people who are getting exhausted, who are helping people who live with diabetes? Say, if you have a disabled family member living with diabetes, or you're the parent of a child living with diabetes, or if you are the adult child of a parent living with diabetes, there's so many different situations. How do we recognize that maybe we're getting exhausted?
Yeah, I think I can't tell you how many times I'm seeing this or hearing about this when I'm talking to my patients, and then the caregiver gets on and they're just exhausted. It's been very challenging for the last 5 to 6 months. I don't know. I think for me, the biggest identifier in this is, if you don't. It's funny. I was listening to Michelle Obama this morning, and she was talking about how she doesn't feel like working out anymore. And she's really been, affected by everything that's happened in the last couple of months. So I think, to me, if you notice as a caregiver, you're not, first of all, not able to care for somebody, but more importantly, that you're really frustrated, you're tired, and then you're really, sort of quickly snipping at your person that you're caring for. I think that's really a problem. But I think for me, if you're uninterested in things that you used to really like to do, to me is always concerning.
Yeah. Yeah. And I think that's where we're seeing a lot of our caregivers. That's what they were telling me. They're actually feeling like they're in function mode. They're robotic. They're able to function. They can do their job. They can do their job really, really well, but they feel like they have nothing to look forward to. So they're just sort of on autopilot. And they said they're kind of scared for having that feeling, because it's a new feeling to them, or a new lack of feeling. So it's kind of really scary.
Yeah. So how can caregivers practice giving care to themselves?
Yeah.
Wow, look at you fast.
That's I think you have to somehow find ways for outlets, and I think peers and other family members, like other family members besides the person you're caring for, can be a nice way to help yourself during this difficult time. And then talking to your providers about this, even though you might not be the one living with diabetes, telling them that what you're going through, I think, is important too. But I think asking for help from your peers and family members, I find it to be helpful for folks. And then obviously the professionals can help you figure out if you're maybe experiencing something like depression or anxiety that you really need some help for.
Yeah. These are some, we just splashed up some 10 tips for family caregivers that included the tips that you were talking about, Dr. Rao, and then ends with just what I think caregivers and people with diabetes should remember: to give themselves credit for doing the best that they have been doing, right? So all of the parts of resiliency can't work together if you are not, in fact, giving yourself a pat on the back and saying, I've done this. And this can go for clinicians who who may be experiencing, exhaustion. It could go for people living with diabetes, for family, for friends. I think we all struggle a lot of times to give ourselves self-love and to acknowledge that we're doing the best that we can do. We tend to focus on what we're not doing.
Yeah.
And so I think to look and give yourself kudos,
Yes,
for doing what you do. Yeah.
And we thank Serena and her group, because in these times, what a great resource your group is and your leadership. So I just want to say, personally, thank you, Serena, for all you're doing. That's just living with it. You're really a great resource to be able to help people.
Maryanne. So that leads us. Oh, Maryanne, thank you so much. That leads us.
That's great.
If anyone would like to join our diabetes peer support group, we are on Facebook. If you go to the search bar and type in Houston Diabetes Peer Support Program, you can access us there, request membership, and one of our admins will let you in.
Yeah, fantastic. And I think that that peer support is a critical part of resiliency, right? Because even as we're sitting here as peers, we are supporting one another in what we are doing together, and validating, the feelings that we have, the stress that we have, and then creating solutions to those things. And so I think to look for peers, whether or not you're a person living with diabetes, a caregiver, I think that is incredibly powerful. And we know that it works through research.
Mm-hmm.
So,
Absolutely.
any final things before we have to say goodbye? We've gone over a little.
I like the patting yourself on the back. I think for patients, for people living with diabetes, without diabetes, I think it's been a hard last couple of months, 5 to 6 months, as you were saying, Joy. And I think we're all trying our hardest out there. And I think it's important to take a step away and say, we're doing the best you can,
Mm-hmm. And yes, I always tell all of my people.
Great, Dr.
Yeah, I always tell my people to celebrate the small successes. If you drink an extra bottle of water today, pat yourself on the back. Don't drink water.
I'm going to take that. I need to do that.
I'm serious. It's people who don't drink water at all. They don't even try. And so if you said, I never drink water, but today I drank a bottle of water, pat yourself on the back, because those small successes can lead to larger ones. So, yeah.
I'm going to take that. That's my takeaway from today.
Oh, that is so awesome. You all, thank you so much for, as usual, being here today, and for helping me even. I feel like I've grown throughout this conversation as well. So thank you all so much. And Thank you, Dr. Rao, for making yourself available again.
You're very welcome. Very welcome. Thank you for having me.
And I hope that you'll welcome another conversation, in the very near future.
Sure. Anytime.
Thank you all.
Thank you.
So it has been another fantastic conversation with my colleagues and I dare say my close friends now. Thank you all for being here. Mark your calendars. We will be broadcasting every Saturday at 10 a.m. Central and 11 a.m. Eastern Time. Our next episode will air on August 15th. We will have, just one moment. We will have Reverend Naomi Washington Liepert here. She's Director for Faith-Based and Interfaith Affairs in the Mayor's Office of Public Engagement in Philadelphia. We will be discussing houses of faith as super settings for prevention of diabetes. Okay. The following week, we will have Food as Medicine. I have wonderful news. Hope Galvin with Harris Health will explore the concept of food and medicine with us and share the experience of working with the Houston Food Bank and other organizations to reduce food insecurity, which we know is growing during COVID among Harris Health patients. All right. So remember that the information we discussed today should not be a substitute for your professional medical advice, diagnosis, or treatment. Always, always seek the advice of your physician. We just wanted to bring you tips today on how to take care of yourself in real time. But remember to get information from your doctor and reach out and have that conversation. Thank you all so much. We can't wait to see you next week.